ICD-10-CM Chapter 6 includes critical rules on laterality, default code selection, and sequencing that can easily be missed. In this video, you'll learn how to apply these guidelines correctly and avoid common coding errors. Welcome to Health Code Blueprint. Today, we're covering ICD-10-CM Chapter 6, Diseases of the Nervous System, codes G00 through G99, with key guidelines and real-world coding considerations. Disclosure. This content is for educational purposes only. Always follow official ICD-10-CM guidelines and organizational policies. Chapter 6 is packed with rules that impact coding accuracy, especially when it comes to laterality and pain coding. In this masterclass, we're focusing on two major areas. First, how to correctly apply laterality defaults, and second, how to master the G89 pain category. Let's start with laterality, because this is one of the most commonly misunderstood areas in Chapter 6. When coding hemiplegia or monoplegia, providers don't always document whether the affected side is dominant or non-dominant. That's when the ICD-10-CM default rules guide us. If the provider clearly states dominant or non-dominant, perfect, code exactly as documented. But when that detail is missing, we rely on the default logic built into the guidelines. Let's walk through the decision pathway. If the patient is ambidextrous, the default is dominant. In other words, you'll assign the code that reflects a dominant side impairment. If the left side is affected and dominance isn't documented, the default is non-dominant. If the right side is affected, the default is dominant. These defaults help ensure coding consistency when documentation is incomplete. Coder tip. When in doubt, remember the rule of thumb: right defaults to dominant, left defaults to non-dominant. Now let's shift into one of the most important parts of Chapter 6, Category G89. Pain, not elsewhere classified. These codes are used to describe acute pain, chronic pain, post-thoracotomy pain, post-procedural pain, and neoplasm-related pain. They're often assigned in addition to site-specific pain codes to provide a more complete clinical picture. Acute pain typically begins suddenly and is caused by a specific event. Chronic pain is ongoing and usually lasts longer than 3 months. But as medical coders, we never determine whether pain is acute or chronic. We code exactly as the provider documents. Because of that, there are strict rules about when G89 codes can and cannot be used. Let's break those down. Rule number 1. If the pain is not described as acute, chronic, post-procedural, post-thoracotomy, or neoplasm-related, do not assign a G89 code. Rule number 2. If the underlying cause of the pain is known, you generally do not assign a G89 code, unless the encounter is specifically for pain control or pain management. This distinction is essential for correct sequencing, so next we'll look at how G89 codes function as a principal diagnosis. There are two main situations where a G89 code can be listed as the principal diagnosis. The first is when the encounter is specifically for pain control or pain management. For example, a patient receiving a steroid injection for severe back pain caused by a disc issue. In that case, the G89 code comes first, and the underlying condition is coded second. The second situation is when a neurostimulator is inserted solely for pain control. Again, the pain code is principal, unless the neurostimulator is placed during an admission for treating the underlying condition. In that case, the underlying condition takes priority. This decision tree helps simplify the sequencing. If the primary reason for the encounter is pain control or pain management, G89 is your principal diagnosis. If the encounter is for a procedure to treat the underlying condition, you do not assign a G89 code. And if the encounter includes both treatment of the underlying condition and neurostimulator placement, the underlying condition is principal and the G89 code is secondary. G89 codes can be used together with site-specific pain codes when each code adds unique information. For example, M54.2 tells us the pain is in the neck, but it doesn't tell us whether the pain is acute or chronic. If the provider documents acute traumatic neck pain, you would assign both M54.2 and G89.11. The site code gives the location. The G89 code gives the type of pain. Sequencing depends entirely on the reason for the encounter. If the encounter is for pain management, the G89 code comes first, followed by the site-specific code. If the encounter is for any other reason, and there's no definitive diagnosis, the site-specific code comes first, and the G89 code is listed second. Always let the reason for the visit guide your sequencing. Postoperative pain has its own set of rules. If the provider documents postoperative pain but doesn't specify acute or chronic, the default is acute. But here's the key. You should not code routine or expected postoperative pain immediately after surgery. That's considered normal and not coded. Let's look at how to code postoperative pain correctly. If postoperative pain is not associated with a complication, assign the appropriate G89 postoperative pain code. However, when the pain is linked to a complication, for example, painful wire sutures, the complication code from Chapter 19 must be reported first. We'll cover Chapter 19 in detail later in this ICD-10-CM series. After coding the complication, you may then add a G89 code to specify whether the pain is acute or chronic, if that information is clinically supported. Understanding this distinction is essential for accurate and compliant reporting. Chronic pain is assigned to subcategory G89.2. There's no time frame in the guidelines that defines when pain becomes chronic. The only thing that matters is provider documentation. If the provider says the pain is chronic, you code it as chronic. It's not about duration, it's about documentation. G89.3 is used when pain is documented as related to cancer, a malignancy, or a tumor. This code is assigned regardless of whether the pain is acute or chronic. And you do not need to assign a site-specific pain code with G89.3, the code already captures the concept of neoplasm-related pain. Sequencing for neoplasm-related pain depends on the reason for the encounter. If the visit is for pain control, G89.3 is principal, and the neoplasm is coded second. If the visit is for management of the neoplasm is principal, and G89.3 may be added as a secondary code if the pain is documented. Again, the reason for the encounter drives the sequencing. Chapter 6 includes 3 pain-related concepts that should never be used interchangeably. G89.0, central pain syndrome. Pain caused by damage or dysfunction within the brain or spinal cord, often described as burning or stabbing. G89.2, chronic pain. Pain that persists for an extended period, typically more than 3 to 6 months. This code is used when the provider documents the pain as chronic. G89.4, chronic pain syndrome. Chronic pain accompanied by significant functional impairment, psychosocial impact, and behavioral changes. As medical coders, we don't assign these codes based on clinical criteria, we assign them only when the provider documents the exact term. Central pain syndrome and chronic pain syndrome require specific documentation of those phrases, while chronic pain is coded simply when the provider states the pain is chronic. To wrap things up, here are the big takeaways from Chapter 6, laterality defaults. Just remember, right defaults to dominant, and left defaults to non-dominant. Easy rule, big impact. G89 as the principal diagnosis. You'll only use a G89 code first when the visit is truly for pain control or pain management. Sequencing. Always let the reason for the encounter guide your sequencing. That's your anchor. Postoperative pain. By default, post-op pain is considered acute, and we don't code routine post-op pain. Neoplasm-related pain. G89.3 stands on its own to capture cancer-related pain. Documentation is everything. At the end of the day, we code exactly what the provider documents, nothing more, nothing less. And with that, we've officially wrapped up our Chapter 6 masterclass. Thank you for joining me today on Health Code Blueprint. I hope this walkthrough helps you feel more confident coding laterality, pain diagnoses, and the G89 category. See you in our next video.